I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist. In this video, we're going to be talking about vancomycin therapeutic drug monitoring in pediatric patients. There's two ways to monitor vancomycin levels. The first is what our video is going to be focusing on, which is trough monitoring. The second is area under the curve monitoring, AUC over the MIC. This measures cumulative exposure over a certain time period, usually 24 hours. This is up and coming in pediatrics. It's pretty much a standard in adults. About 50% of institutions will also do this in pediatrics. So if your institution practices this video is not for you, but if you still do trough monitoring in peds, you will learn how to do trough monitoring here. For neonates, there's not enough population data to do AUC monitoring, and so trough-based monitoring is still the gold standard for neonates. So trough-based monitoring for neonates in pediatrics is what we're going to be talking about today. So the reason that we need to do monitoring is to, one, improve efficacy for our gram-positive infections, and also to minimize toxicity. Really, nephrotoxicity is the major toxicity that we want to avoid because vancomycin has a very narrow therapeutic window. Our goal trough depends on what we're treating. For empiric treatment and for coagulates negative staph, this would be for neonates, the goal trough is 10 to 15. 15 to 20 will be your goal for MRSA infections, meningitis, other serious infections. The reason that we don't have 10 to 20 for everyone for the goal is that troughs over 15 are associated with more nephrotoxicity. So we reserve this. So for neonatal empiric sepsis, for example, 10 to 15 would be your goal. If you're super concerned for MRSA infection or you have a true MRSA infection, osteomyelitis, endocarditis, 15 to 20. In terms of timing of the trough, we get the trough when we've reached steady state, which is just before the 4th dose. I will get it earlier only if I suspect a super therapeutic level, like if maybe renal function has started to decline and I'm worried that the level might be high already, then I might get it early. But for the most part, we want to wait till we reach steady state concentration so that we can accurately assess the trough, or else the trough will be artificially low if we get it too soon. And we want to get the trough about 30 minutes to 60 minutes before that dose so that it's the most accurate and we have time to get it back and then act on that. Vancomycin has both time and concentration dependent activity, so you can adjust either the interval or the dose. I usually like to adjust my interval first, and then if I'm at either end of my intervals, so if I'm at Q6 but my trough is still too low, and if I'm at Q24 but my trough is still too high, then I adjust the dose. But totally up to you, you can do either one. So if your trough is low, you can narrow your dosing interval. So for example, from Q12 to Q8 hours, and then you repeat your trough before the next 4th dose. If it's high, you would increase or widen your interval, right? So from Q12 to Q18, for example. Or you can go up or down on your dose by 20%, depending on what your trough is. If your trough is greater than 20, I would hold your dose for one dosing interval and then repeat. And then you can restart when your trough is below 15 if your goal is 10 to 15, or below 20 if your goal is 15 to 20. That's just to make sure that you don't cause AKI from a super therapeutic level. Over 20, there's a pretty high risk of that. A common question I get is how much I can increase the dose. For example, if your trough is 4 or 5 and you're sure that all of the doses were given up until that trough, because we want to proportionally change our level based on a dose change, 20% is usually the rule of thumb. So a 20% change in the dose will produce a proportional about 20% change in the level. 33% is the maximum allotted increase, because past 33%, we can no longer correlate that change in dose with a change in the level. So if you absolutely have to, you can increase your dose by 33% max, but really I try to stay with that 20% change. While on vancomycin, monitor renal function at least every 72 hours. Every 24 hours if the patient is unstable or if you're on a concurrent medication that's nephrotoxic, like gentamicin, for example. When to repeat the trough also depends on the stability of the patient and concurrent medications. So you want to repeat it at least weekly, but sooner, I say usually every 72 hours if the patient's unstable or if you're on a concurrent nephrotoxic medication, just to make sure the trough is still correlating well with the current renal function. Thank you so much for watching. If you liked this video, please subscribe and let me know in the comments what topic you'd like me to cover next.